Okay, so we're moving on to fibrous lesions of the soft tissues. So, Elior, what do you think is going on here? And this is what we're concerned about.
Right, okay. On the plantar aspect of, is it the flexor tendon of the fifth
Yeah,
digit
I don't
there?
have the flexor tendon here, but you're probably pretty close to the fifth metatarsal head here. Let's see what else we have. Here the coronal image, a T1 weighted coronal image.
Right, on T1, it's intermediate signal, a little lighter than muscle. On the PD fat side, I mean, it looks closer to fat. I mean, in this location, I would think a chronic ossification center or pressure
Yeah.
center.
Yeah, so I think that that's what this is, a pressure lesion. It's overlying areas of bony prominence where you get repetitive compression of the subcutaneous fat. John, were you going to say something?
Yeah, it's basically a callus,
Yeah.
simply put.
Well, Elior just left the meeting. Okay. Yeah. So these are kind of fibrous in histology. And as John said, it's really a callus formation to help protect the underlying bone from repetitive trauma. Okay, Tayson.
Okay, yeah, Elior left the meeting because we're getting too much feedback, so we're just going to share this.
Oh, okay. Good.
All right, it looks like this nodular lesion arising from the plantar fascia. It's probably
Okay.
mitosis.
Yeah, here we can see this is an old-fashioned T1 and a stir sequence, and this is plantar fibromatosis. Okay, Robert.
All right. Yeah, this one looks similar to the last case, plantar aspect of the foot there. There's hypointense tissue and a little bright on the, what is that, stir imaging?
All right. This is PD fat set in the coronal plane here. Right. It is associated with the muscle here, so you might think of other things, but you're right. This is very characteristic of another plantar fibroma. So they resected this completely. I don't have an image right after the resection, but the patient came back a few years later and was rescanned. Here's 2.5 years later. And so what do you see here?
Yeah, it looks like some recurrence of that tissue.
Yeah, with a little different signal characteristics this time. But there's the lesion. And when this was removed again, this was a recurrent plantar fibroma. Though when it came back, it had a little bit more fluid signal within it than the original lesion. So there are a lot of different ways to categorize fibromatosis. Superficial fibromatosis, you've got deep, which is like Dupuytren's contractures that we talked about in the wrist and hand. Plantar fibromatosis, it comes by other names, and so forth. And extra-abdominal desmoid tumors. Abdominal desmoid tumors tend to be much more concerning for malignancy than these other peripheral lesions. And then this is just another paper where they talked about a desmoid type fibromatosis. And okay.
John, from
yes.
an orthopedic standpoint, the main thing about these lesions is that they have a tendency to recur. So when you do excise, and you better tell the patient that's a great possibility.
Okay.
And when you do excise them, you have to do a big excision with a lot of normal tissue has to go as well.
Okay.
And it's a big decision to make, almost a decision of operating on a cancer.
Thank you.
Um,
Okay. Okay. Elior.
Okay, we have a 19-month-old boy, mass noted by mother, otherwise normal. So radiographs here, skin marker, yeah, along the posterior arm. I don't see anything. Yeah, ultrasound. Yeah, soft tissue lesion with some internal vascular flow. Okay, so we have is it a PD fat set on the left? Maybe
Yes, there's the PD fat set on the left, T1, and a post T1 fat set post on the right.
okay. So or like in the tricep muscle surrounding that tendon, there's a lesion with contrast enhancement, not very volume positive, just some focal
Okay.
enhancement, I guess.
Yeah, with some kind of a little bit of irregular margins and a little bit of indistinctness of the margin boundaries there. And this was a fibrous hamartoma of infancy.
Okay.
Oh, I thought I had more things. Maybe yeah. I think what you'll see from a lot of these is that it's probably impossible to make actual histologic tissue diagnoses on most of these soft tissue masses just based upon MR criteria. The best thing to do is try to be able to differentiate due to location, signal intensity, and types of contrast enhancement, whether a lesion is likely to be aggressive or non-aggressive. And most of the people I know who deal a lot more with tumors than I have been burned at one time or another in the past when they try to rely on MR to make a tissue type diagnosis. So they tend to be, the more they're in this field, the more they get aggressive with doing biopsies to get actually a tissue diagnosis. Okay, Tayson.
All right, middle-aged male with history of trauma, now with mass. So it looks like we're in the pelvis near the insertion of the iliopsoas tendon, and there's this heterogeneous fluid and edema there. Could be iliopsoas bursitis or hemorrhage. Not
Okay.
exactly.
Yeah, so it looks like it's really more mass-like, but certainly could be hemorrhage, could be a hematoma with a tear of the muscle, because the patient did have a history of trauma.
Yeah.
Turned out the history of trauma was a while ago, not recently. Here's what it looked like on the coronal stir sequence.
Okay. Yeah, it looks like some low signal surrounded by edema and
Right. So there's a
fluid.
lot of very low signal with edema around it going into the soft tissues. So again, maybe this is a hematoma, but this is pretty low signal intensity, though this is a stir sequence, for just kind of calcification. What else might you want to do to characterize a lesion like this? Fortunately, I don't think I have that study here.
Radiograph or a CT?
Right. A radiograph, because you'd like to know how much calcification this is. And this was actually all bone, but I didn't get the x-ray. It was just described to me over the phone from the clinician. And they removed this, and this turned out to be myositis ossificans.
Okay.
The point here is that myositis ossificans can look pretty aggressive on an MR examination. So you have to keep that in your
the problem with this condition, you excise it, you get a bigger one afterwards, unless you wait at least a year from the time of injury. So excision is not something that is recommended. Yeah. this is not the usual location of these.
Yep.
I'm sure you know that, but usually it's a quadriceps. But these you operate and you may have more problems than before surgery.
Thank you, John. Okay. Robert.
Yeah. So we have a 28-year-old female with a leg mass, and looking at the posterior compartment of the lower leg, looks like there's, on the left it looks ovoid, but on the sagittal imaging it looks pretty elongated, and it's pretty heterogeneous. A lot of low signal, a lot of high signal.
And then you need to describe the margins. The margins are pretty distinct here, though there's some indistinctness over here, but it doesn't really look like it's infiltrating. The margins are really pretty well defined.
Yep.
Okay, so what do you think?
I'm not entirely sure what it is, but
Okay, so here's the stir sequence. Actually, you can see a little bit of edema around it. But remember, you commonly will get edema around malignant type lesions. And this turned out to be an extra-abdominal desmoid tumor. Now, and as I kind of referred to earlier, outside the abdomen, these tend to be benign lesions. Inside the abdomen, they tend to be more likely to be malignant. But see how large this is. I could show you a very similar lesion, which would be a malignant lesion. Because again, if you remember, size is also a major component to increase the risk for malignancy. So I would really think that you would have to put this in the category of a potentially malignant lesion in the workup on this particular case.
And it has to have a wide excision also. These recur. One thing that was it Robert that just talked?
Yeah.
It's a lower leg and upper leg. We have a lower extremity, but then when you have a leg and then the thigh and the upper leg, we don't have a lower leg, and if we use real orthopedic terminology.
So it's thigh or leg, and this would be on the leg.
Gotcha.
So it's a kind of you can confuse people sometimes.
Okay.
You don't put it properly.
Okay. Or you could say calf. Alrighty. Let's see. Elior.
All right, so 49-year-old woman, hard soft tissue mass. So the anterior ankle, on the radiograph on the left, just some soft tissue thickening. On the MR, on these T1, I think T1 image on the second image, and then with contrast enhancement on the right.
And T2 here.
Oh, T2, okay. Yeah, pretty low signal on T1 and T2. Very minimal surrounding edema. Let's see, on these axials, looks like they're in the anterolateral gutter. I don't think they're associated with the bone or surrounding tendons. Not sure. Okay.
So this was a desmoplastic fibroblastoma. So again, it looked kind of like a fibrous tumor, but it has inhomogeneous signal intensity and maybe enhancement. Well, again, we need a T1 FAT-SAT pre in order to really determine that. But it has this kind of characteristic that looks like fibrous lesions. But again, you can't really differentiate whether it's malignant or are not malignant based upon the MR criteria here very well. So again, this has to be put in the category of a potentially malignant lesion, in my opinion. Even though this is probably, because of the histology, going to be benign.
Well, it doesn't have an invasive look to it,
Right.
and
I
so
agree.
that kind of puts it more in a non-cancerous lesion. But nevertheless, if you excise it, you better take it, all of it out, not part of it.
Yeah. I just want to know, when they're this inhomogeneous, I've seen some lesions that really don't look like they're infiltrating, but ended up being malignant. So,
Yeah.
again, you've got to be, if in doubt, remember, you can't really exclude malignancy unless it's one of the very unusual, obvious lesions that we all know about.
Well, the thing about bone pathology is, in terms of tumors, you specialize in these, and even the Armed Forces Institute of Pathology, they get fooled also. When in doubt, that's probably where you want to send a specimen.
Yep.
With your MRI.
Okay. I'm sorry, I didn't. Who was the last person?
Yeah, I think it's me.
Okay.
37-year-old female. So looks like within the gluteal musculature, there's this round lesion there, increased signal on fluid sensitive sequences, and I guess ISO intends to muscle on that T1.
It's heterogeneous. There are areas of the periphery which are kind of indistinct.
Yeah. Yeah, in some areas internally, probably more
Yeah.
fibrotic.
And what else do we see here that should make you very concerned?
Um,
It's extending through a major soft
fluid.
tissue plane here,
Okay.
right? Going from basically one compartment to another. And that's highly suspicious for malignancy. Oops. And this was a dermatofibromatosis, so it'd be a high-risk case, though I think histologically this would be benign, but this is another lesion that I would be worried about.
Okay.
Okay, see, Robert.
All right, so we have a 40-year-old female with right foot pain 3 years ago. Had right foot dorsum excision of a possible neuroma. So here on the T1 imaging, it looks, hypointense, pretty large mass, kind of centered about the first and second intermetatarsal spaces. It's bright on the PD fat set imaging, and I'm assuming this is contrast enhanced here.
I'm not sure whether this, yeah, could be, or it could be a Fastman Echo T2. I'm not sure which. So what are your thoughts here?
So I'd be concerned for a recurrence of a neuroma.
Yeah. So they thought, well, maybe this would be a endodigital schwannoma, and this turned out to be a plantar fibromatosis. So we don't know about the first one. I think Dr. Su thought that the first one was misdiagnosed and actually mistreated at a local clinic where they excised what they thought was a neuroma. It was probably fibromatosis at that time, and as John said, you have to have a wide excision and treat those very aggressively, and this one came back.
And also pathologically, under the microscope, they look malignant, very, very hypercellular.
Okay.
And the only thing is you don't see too I don't remember whether you see a lot of mitotic figures or not. But it does. It's some small cells, and they're very, very packed together and
Okay.
very hypercellular.
Okay, Elior.
Okay, we've got bilateral scapular pain, chronic. Um, Here, I think we're looking against the lateral chest wall. We deep to the sartorius, anterior sartorius muscle. On the left, it looks like there's a very indistinct mass, mixed signal intensity. Is there something on the right? I'm not sure.
Well, this is abnormal, and
Uh-huh.
this is all abnormal here. And it's pushing out the normal muscles.
Yeah.
So what might this be?
I know this is
Unilateral or it can be bilateral.
the location is, classic for elastofibroma.
Yeah, so this turned out to be bilateral elastofibromas. Good. Been there for a long time. Okay, Tayson.
I have mass at left thigh. So within the anterior musculature, we have a T1 hypointense, T2 hyperintense lesion there. It looks like it's well circumscribed. It's a very increased signal on
Mm.
the fluid sensitive sequence. Um, some other type of fibrous lesion. I'm not
Yeah,
sure.
so this was removed and it was a solitary fibrous tumor. Again, a benign lesion.
Okay.
Okay. So they're rare soft tissue tumors, variable malignant potential, and therefore they really need to be excised, usually, and they can be in multiple sites. And this just talks about different things you see. You can see smooth, lobulated contours, very discrete margins, and they enhance heterogeneous signal intensity, and you don't see any calcifications within them. Okay, Robert.
All right, so we have a 20-year-old female with mass enlarging for 1 year.
Well, that's the thing is that we validate
Let's see. I think we're looking at, is that the thenar compartment?
Yeah.
Yeah, there's a bright mass there. The margins aren't very well defined. Yeah, here it looks kind of aggressive and almost spiculated,
Right.
infiltrative.
Yeah. So what do you think this might be?
I'm not entirely sure.
Yeah. And there again, you can see these kind of spicules of what looks like tumor growing out into the tissues. And this was a desmoid type fibromatosis again. They're very aggressive, typically do not metastasize, but can be very locally aggressive and require wide margins to get rid of them. Okay, Elior.
Okay, so we're looking in the second intermetatarsal space. This looks like a young patient. On the PD FET set, like axial on the left, it just looks very well circumscribed, high signal. It's very cystic. On the T1, yeah, very low signal. Looks like muscle. On the post, yeah, see enhancement, pretty homogeneous enhancement. Yeah, I'm not. Could this be a well, I was gonna say neuroma, but such a young patient, I would think maybe a fibrous, yeah, another fibrous tumor.
Yeah, this turned out to be a sarcoma. It has sharp margins. You don't see a lot of infiltration, uniform enhancement, but also you can see a pretty uniform signal intensity. So it looks like a pretty non-aggressive lesion, but it
Right.
was a sarcoma. And so it did have metastatic potential. Okay, Tayson.
All right, 23-year-old female with recurrent mass in the right thigh. You see this ovoid, low T1, high signal on fluid sensitive sequences. And we have this split fat
Right.
sign here.
Yeah,
Makes me
Dr.
think
Suit
of
likes that sign.
a neurogenic nerve sheath tumor.
Certainly could be in that category. And you can actually see nerve sheath tumors in muscle like this. It's pretty uncommon, but I've certainly seen that. And that would be my first choice here as well. But this turned out to be a dermatofibrosarcoma. So inside muscle, if you see any mass lesion inside muscle, benign lesions don't like to sit inside muscles. So anytime you see a muscle lesion, a mass lesion, you've got to be very suspicious because that benign lesions just, I think, don't like being in a situation where there's such a big change in pressure uh, uh, with contraction and lack of contraction of the muscles. So be concerned. This is a dermatofibrosarcoma. That's very uncommon. I have seen very few of these. More common would be a myxoma, which is a less malignant, but still a potential malignant lesion. And so my first thought here, if I were dictating this, would that this would be a one of those lesions. Okay, let's go on to fibrohistiocytic lesions. Okay, back mass for 5 years, pain in the supine position.
All right. At least on these X-rays, I don't think I see a whole lot here.
Yeah, it's really hard to see anything back here.
All right. Now we have some MRs, and there's some fat sat imaging, and it looks like there's a bright lesion, kind of paraspinal soft tissues. It's kind of almost directly centered over the spinous process in that T-spine. Looks pretty well defined.
Yeah. There's the ultrasound. Doesn't look cystic.
Yeah.
This was a benign fibrohistiocytoma. Okay, Elior.
Okay, so T1 on the left and with contrast on the right. See this heterogeneously enhancing mass. Looks pretty well circumscribed, involving the intermetatarsal space there. I mean, looks pretty benign. Looks very well circumscribed with the enhancement.
Yeah, this
Okay.
turned out to be a giant cell tumor of the tendon sheath. Yep. They don't have to be low in signal intensity. Okay, Tayson.
All right, 55-year-old male, status post, giant cell excision, assistance to evaluate for amputation. Well, I guess the giant cell was excised from the fourth digit there, and then yeah, dorsal to the fourth digit, we see this low signal heterogeneous lobular mass kind of associated with that IP joint.
Okay,
It's a
so that's
recurrent.
recurrent PVNS. Good. Roberto.
All right, so now we're looking at the ankle. Uh, Looks like there's some measurements on a stiata process there, and then
Okay.
adjacent to that, uh, looks like there's some hypointense soft tissue, some scalloping of that upper calcaneus area.
I think when you see that, you start thinking a cancerous lesion, and that kind of always bothers me when I see erosion in bone.
Yeah. So now we have a T1 fat sap pre. It looks heterogeneously bright.
Yeah. So this could be synovial tissue, and maybe it's a synovial erosion. There's the post.
Uh, yeah, there may be some enhancement in there centrally.
But it's very bright on both.
Yeah.
Okay. And this was PVNS. But PVNS certainly can erode bone. But this is an unusual location. So this is actually more within the joint space rather than a tendon sheath. But it's associated with synovium. So this is really kind of a chronic synovitis with erosion here. Okay. Elior.
Right. So we've got radiographs looking at that proximal phalanx, see erosive change, adjacent soft tissue thickening. Yeah, soft tissue mass with again some bone erosions. Maybe is it associated with that tendon? It's deep to the tendon. T1 above, IV contrast below. Looks like yeah, we have a contrast enhancement. Is this another giant cell?
Yeah. And the giant cell tumor of the tendon sheath. Yeah, you can also get fibromas of the tendon sheath. Okay. Tayson.
All right. So it looks like at the middle finger, there's this heterogeneous mass that's encasing the flexor tendons. I guess there's some peripheral areas of enhancement there. Some other, yeah. Oh,
And this turned out to be an epitheloid sarcoma. And here we can see more non-uniformity of the enhancement than you would expect with just a synovitis type issue. In this case, you've got skip lesions. And this looks more aggressive, but then with that recurrent PVNS, that was a very aggressive lesion as well. So so you just have to be maintain some level of suspicion when you see any findings that look like aggressive nature.
okay.
Can be calcified. Okay, Robert.
All right, so we have a 44-year-old male ankle mass, an excision at a local clinic 2 weeks ago. Looking at the radiographs, it looks like there's some prominence of soft tissues overlying that distal fibula laterally.
Yeah.
Yeah, the ultrasound, MR. Let's see, we have was that a T2 on the top left?
Yep.
Yeah, there's a lot of prominence of soft tissues there as well. Yeah, that looks a little some cystic foci in there, some bright foci, and then there's a bone scan, I think.
Uh,
Some kind of scan.
no, it's a scan. To be honest with you, I'm not sure. I would have guessed a PET scan, but it doesn't really look like the way we would present a PET scan.
Yeah.
Okay.
And so it looks like he underwent resection of that. It looks, I'm assuming some sort of malignancy. Just
Yeah, so this was a malignant fibrous histiocytoma. And I think nowadays a lot of people like to use the term undifferentiated pleomorphic sarcoma. So let's move on to smooth muscle. Elior.
Right, so we've got a lesion in the inner thigh, distal thigh on T1. Some low signal, looks well circumscribed on that coronal view. On this, are we sagittal there?
Yeah.
Yeah, these marker, yeah, this is a PD fat sat or
I think it's a post-contrast.
oh, okay.
Yeah.
So assuming some contrast enhancement, indistinct margins.
You know, again, we don't know without the
Sure.
pre,
Yeah.
because a lot of these solid tumors can be very bright on a T1 fat sat image.
Mhm.
It confuses people, but on the other hand, it's very inhomogeneous, so it has very sharp margins here.
Mhm.
Here it looks like it may be associated with a vessel. We probably want to look at the axial images and see if it's encasing a vessel, because that's always an ominous sign if it actually encases a vessel. So what's your differential here?
Yeah, it's
So there are the axials. So it's not encasing the tumor.
it doesn't, it looks like it's within the fat,
Yeah.
doesn't involve the other structures. Yeah, I mean, could it be, yeah, like a smooth muscle type of tumor surrounding the vessels, maybe?
Yeah. So it's a leiomyoma. That's what this turned out to be.
I think so. What's interesting is the muscles are quite atrophied.
Yeah. So this leiomyoma is in much better shape than the skeletal muscle. Yeah. Okay, Tayson.
All right, 45-year-old male with mass for 6 months. We have stir and T2 images here. Was this on in the shoulder, superficial tissues? Looks very heterogeneous internally, with some areas of cystic degeneration. Yeah, and yeah, definitely some areas of internal necrosis and kind of
Okay.
fixed enhancement within there. Again, probably a smooth muscle tumor.
Okay. So pretty well maintained, but we see a lot of inhomogeneous enhancement, which is a very worrisome sign, like it has outgrown its vascular supply. And here we can see it in the sagittal plane, similar characteristics, and this was a leiomyosarcoma.
Yeah. Okay.
Skeletal muscle. Okay.
all right.
Yep.
I think it's me.
Yep.
So we have a 27-year-old female with a thigh mass, and it does look like there's an intramuscular thigh mass associated with the vastus intermedius, slightly increase in signal relative to the muscle. And yeah, so it's bright on the PD imaging and also the T2 fat sat imaging. Not really well-defined borders on these images, and looks like it likely enhances, although we don't have the pre-imaging.
Right. So what's your differential?
I'd be concerned about some sort of, vascular mass, just given how much it looks like it's enhancing. But
So it could be a hemangioma, an intramuscular hemangioma. Yeah. So this was an alveolar part sarcoma, which is a significant malignant lesion here. So, I mean, you can, once you see that it's a solid mass, the vascularity should make you be very concerned that it's an aggressive solid mass. So that would put it in the category of a sarcoma. If you see, you can certainly do ultrasound and look at what the flow characteristics look like, but I think that's a bit nonspecific. If you look at the mass itself, it really looks more like a mass rather than just a collection of tangled vessels. You'd want to get a plain film to see if you have phleboliths, because you'd feel much more comfortable if it's a phlebolith, which this one did not have. And you can see here that there are a lot of hypervascular masses on MR, many of which are sarcomas. So if you see indistinct margins, hypervascularity, a lot of mass and not just vessels, and no phleboliths, you got to work it up, assuming it's going to be a sarcoma, including metastatic disease.
And it doesn't have any cover to it. It just looks like it's spreading out
Yeah.
with no fence around it.
Yeah. Elior.
Hey, we've got a 4-year-old boy, left leg swelling and fever, left post-thigh painful swelling and fever for a week. Elevated inflammatory markers, lab. Let's see, on the radiograph, I'm not sure I'm seeing much in the soft tissues. Okay, on the MR, the posterior left thigh, we see this is edema.
Okay.
Fluid sensitive sequence.
Yeah.
Not sure if I see a distinct mass here, but there is edema involving that muscle.
So at this point, it sounds like an infection or some sort of inflammatory thing, right?
Ultrasound, sure.
A little
See
bit
some
of vascularity,
edema
but not a
muscles.
whole lot. No real through transmission, but yeah, some vascularity.
A month later, okay, there's some more fullness there in that muscle, which would make me concerned for a mass.
Yeah, here it looks more mass-like.
Mm-hmm. So like a rhabdomyosarcoma patient of this age, maybe.
Much more looks like mass here. You know, I'm sure they worked the patient up for infection before, and that was negative. And here we're seeing a lot of edema, definitely increase in the mass very rapidly. So I'd be very worried. And this was an alveolar rhabdomyosarcoma. Good. Okay, Tayson.
All right, 5-year-old male with left buttock swelling for 1 month. It's in the left buttock region. There might be some increased fullness of the soft tissue on that more coned in view, but that might be reaching here. Okay, yeah, so it was in that area. So it looks like a well-circumscribed low T1 signal mass. Yeah, homogeneously intermediate signal with some areas of cystic changes internally.
Right.
Another sarcoma.
And you can see that it looks like some large vessels going to it, cystic changes. It's extending out from the muscle out into the subcutaneous fat here. Looks like it's aggressively there with a lot of inhomogeneous. You'd be concerned about areas of death of the underlying tissues here from outgrowing its vascular supply. Here's a PET scan.
Yeah, so avid PET uptake. So yeah, it'd be for a malignant sarcoma.
And so this was an embryonal cell rhabdomyosarcoma. Yeah, in kids, these kind of masses tend to be, unfortunately, malignant. Okay, and then here we can see actually that there are a few little mets, which these things like to do. Yeah. So tend to be in the young kids.
These are very aggressive.
Yep. Yeah. Okay, vascular lesions. Robert.
All right. So it looks like there's a rounded lesion associated with, I think, is the popliteal artery, posterior aspect of the knee.
Hey,
Yeah, it's.
so what do you think this is?
I'd be concerned about an aneurysm just given the appearance, but yeah.
Yeah, so this is a popliteal artery aneurysm, a big popsicle. Okay, Elior.
Okay, on the plantar aspect of the forefoot, this multilobulated lesion is bright on
Stir.
T1 fat set, or
I think this
maybe-
is stir,
okay,
and I think, yeah, this is a T1.
T1. Okay, very like serpiginous, vessel-like. We're in the vascular section. A malformation, I would think. Is that a phlebolyth
There you
right
go.
there?
That's a
Okay.
phlebolyth. So you want to get an X-ray, and there's your X-ray. There, your phlebolyth.
Okay.
So what is this?
I got a venous malformation.
Right, or hemangioma.
Okay.
Good. Yeah, venous malformation is probably the most accurate description. So vascular formations, you can have low flow, which can be capillary, venous, lymphatic, or mixed, high flow, or AVMs, and then you can get vascular. Now, true hemangiomas actually are different from what we normally call hemangiomas. These are very rare. That's actually an endothelial tumor. But so you can get actually true hemangiomas, which are benign endothelial tumors, and there are other ones like that. But most of what we call hemangiomas are these capillary and venous malformations, primarily venous malformations. So with low flow malformations, you don't get signal voids, you don't see any AV shunting. It's a lobulated type mass, just like we saw. You can have septa in it, just like we saw. You can get fluid lakes, and then phlebolyths are really very helpful. And you get, if you give contrast, and you get delayed contrast if you actually do a flow kind of contrast study. If you do just a typical equilibrium contrast study, then that's not very helpful. And with lymphatic, you get non-enhancing voids in the delayed phase of enhancement. High flow, you typically see signal voids on MR. You don't see much of an enhancing mass. And then if you do a MR, dynamic MR study, you can see contrast very early on, usually within 20 seconds of the injection. Okay, who's next?
I think it's me.
Thanks, Tayson.
All right. So looks like plantar to the forefoot. We have a lobular lesion with multiple fluid levels. Makes me think of some vascular, maybe so it's kind of different here. This it's very regularly marginated. I don't know, is this some sort of lymphatic
Well,
malformation?
you have fluid levels. Now, this would be a this would be a capillary, capillary malformation, or what we usually call hemangiomas.
Okay.
Yeah. And again, I'd want to get a plain film on something like this to look for the fibrous to confirm it.
Okay.
Okay, Robert.
All right, so we have a 2-year-old female with a mass lesion in the right buttock and posterior thigh for 1 week. Non-specific past history, I think. So yeah, looking at the X-ray, it does look like there's some asymmetry in the soft tissues of the thigh. But other than that, I don't think I see a whole lot. On the FATSat T2 imaging, there's this large multilobulated mass, heterogeneous, some internal foci of decreased signal that look brighter on the T1 imaging.
Yep.
And
Funny enhancement pattern with gadolinium.
yeah. Doesn't look like there's much flow on the ultrasound.
Okay, so that's helpful. This is what it looks like when they took it out. And this was a cavernous hemangioma, a lot of hematoma and a lot of hyaline thrombi. So you can have hemangiomas that don't look very vascular on an ultrasound. Okay, Elior.
Okay, so we're in the arm here. Looks like maybe we're within the muscle. This well circumscribed mass. Yeah. So that's the stir. Very
Yeah,
bright signal on the right. Sorry, is that stir?
I think this is stir. I think this is stir, and I think that's T1.
Okay.
8105. Here are the axial images. Very inhomogeneous signal on the. This is a PD fat set. This is a T1.
Okay.
Oops. I was supposed to ask you what you should get next.
A radiograph to check for phlebolyths.
Okay. And notice how it grew significantly from 8105 until 82108. And now we can see a lot of phlebolyths in there, much larger mass. And then those low signal things that we were pointing out before, these are the phlebolyths within it that we could see actually on the first study as well. Much larger mass, and then we can see the phlebolyths. So these can grow significantly. Okay, Tayson.
All right. Right thigh, focal swelling for 7 years. Just kind of heterogeneous signal on the ultrasound and that subcutaneous tissue there. And yeah, kind of ill-defined region of low T1 and high T2 signal intensity. Yeah, it just looks very regular, non-mass-like appearance to it.
Yeah, this was a lymphangioma.
Okay.
And again, just gotta categorize these different kinds of vascular malformations. Okay, Robert.
All right, so we have a 52-year-old female with decades-old mass and increasing size and pain for 2 years. Looks like we're looking at the form. There's surrounding the radius and I think ulna as well. There's some soft tissue that looks a little bit brighter than normal muscle. And yeah, on the post imaging, it looks like it enhances pretty avidly. So
What's
similar. That's a good question. That's not enhancing.
So this is what a lake looks like.
Okay.
And what does that make you think about?
Some sort of lymphatic.
Right. So that's typical. This is a typical appearance that you can see with lymphatic malformations, where we have a big area of non-enhancement, and so this was another lymphatic malformation. Okay, Eliora?
Okay, we have a 25-year-old.
I want to check
male.
something here for a second. Okay.
So we're looking at this subcutaneous mass. It has some internal flow. Yeah, on the MR, fluid sensitive sequences, this lobulated mass looks like it connects to a vessel there. Yeah.
Maybe an artery and a vein.
Mm. Yeah, it looks like maybe a varicose vein on the top images. It looks, the bottom right image, it looks a little more infiltrative in that muscle, but
Okay.
you know, I would think a venous malformation maybe.
Yeah, good. Excellent. Well, why don't we stop here and we'll pick up at this point tomorrow. Okay?
Okay, thank you.
Thanks,
Thank you.
everyone. Thank you.
Okay.
Bye.
Take it easy, everybody.
Thank you, John.
And happy Friday tomorrow.
Right.